We can see the screen.
You can see the screen.
Yeah.
I guess I should introduce.
So just start video. It's not. You may
Yeah.
just use your phone, but
No, it'll give me the echo, so I don't.
here it goes. Start.
Hi, everyone. Can you just verify for me? We're using Zoom. Can you verify for me that in the chat whether you can hear us?
We can hear you.
Wonderful. Thanks. This morning, yesterday was a wonderful day. This morning had a slight glitch and technical issues at the Osler, but we're up and running. Yesterday, I had the pleasure of introducing Dr. Novitsky, who is really internationally known for his expertise in advanced laparoscopic and robotic surgery and in the management of complex hernia. He is a professor of surgery at Columbia College of Physicians and Surgeons and the chief of the Division of Abdominal Wall Reconstruction at the Department of Surgery at Columbia in New York City. He is known for his pioneering and innovative techniques in minimally invasive ventral hernia repair, as well as robotic and open abdominal wall reconstruction. He has essentially had the TAR procedure, which is a landmark procedure and a game changer in abdominal wall reconstruction. He's an immediate past president of the American Hernia Society and now leads their practice designation task force. Dr. Novitsky has actually received over $2 million in grants from the NIH and many professional societies to improve hernia repair and mesh and researched this and published over 130 peer-reviewed publications, as well as editing the highly acclaimed hernia surgery current principles and practice textbook and the Atlas of Robotic General Surgery. In addition to his clinical and research activities, he's also active in medical education and is the fellowship director for their abdominal wall surgery fellowship. Dr. Novitsky earned his medical degree at Albany College and completed residencies in general surgery at Mount Sinai and the University of Massachusetts, followed by fellowships in advanced gastrointestinal and minimally invasive surgery at the Carolinas Medical Center under Dr. Henneford. So thank you again, Dr. Novitsky, for coming. We are really glad to get underway. And thank you for a wonderful day yesterday and what's sure to be a great talk today.
All right. You guys all set here as well? Not really. All right. Good morning. Again, we're figuring it out. So great to be here, and certainly it's been a great time spending some time at McGill surgery and participating in graduation activities, but onward with the lecture. And yesterday my talk was quite technical, just really showcasing the beauty and the sort of elegance of modern techniques. And today I sort of want to switch gears and really approach this from a different angle. And you can see the title of my talk is about changing the landscape of abdominal surgery. These are my disclosures that should not be at all pertinent today. So the question is, why hernia abdominal wall surgery? And that was never my plan during my training. I trained at the University of Massachusetts in general surgery after a brief start in New York City. And I came across Professor Demetrius Lidwin, who at that time was this young gun from Canada, from Toronto, trained HVB surgeon who was one of the pioneers of laparoscopic surgery. He actually published the first paper of Trans-Canada experience on lap chole. Dr. Fried was one of his compatriots at that time. So he came to UMass and certainly was instrumental in me developing my interest in laparoscopic and minimally invasive surgery. As a result, I did some research with him. We studied immunology of surgical stress, immunology of laparoscopy. And with that, I continued my training in Charlotte, North Carolina, under the guidance of Professor Hannaford, and really trying to learn minimally invasive techniques and hoping to have a career doing laparoscopic Nissens, adrenalectomies, splenectomies, and that's really what I wanted to do. But throughout that time, and I always say this is where my hope of doing these things began to die, and I got exposed to hernia repairs and mostly laparoscopic ventral hernia repairs, and Todd was one of the pioneers of that approach. And really, from that point on, I became very interested in the disease process. And another way why we talk about it is are the statements like this. And a surgeon can do more, and no disrespect to our surgical oncologists, but this was said in 1948 by Sir Cecil Wakely. Surgeon can do more for the community by operating on hernia cases and seeing that his recurrence rate is low, that he can by operating on case of malignant disease. And it's just a testament of how common this process is and how debilitating and hernia, especially in recurrent hernia, can be, and how much of trouble in terms of quality of life this may cause. And hernias come in so many shapes, and one of the challenges is to really recognize this tremendous spectrum of the disease. It's a belly button hernia, and if you look at these pictures, sometimes it looks easy, but this is often people who come in with really difficult hernias, they look back that it all started off something relatively straightforward. And you can see this is just a collage of a variety of patients who have different locations, different sizes, skin involvement. This particular gentleman has a ventricular peritoneal shunt that's coiling in his hernia sac. Significant skin attenuation, scrotal components, really large scrotal components, and if that's not bad enough, something like this in the setting of ileostomies, flank defect with or without kidney transplant. This is not a side shot. This is the front shot of somebody who has a chronically infected flank wound, multi-site hernias. And again, this patient has a kidney transplant on the side there. Really large progressive defects with chronic contamination, loss of abdominal domain. This particular patient had a belly button hernia about 15 years prior to that, and 7 operations later, this is how he is today. Young people who have either trauma or or operative catastrophe with unrecognized bowel injury, and then end up having treatment for the open abdomen, something in the setting of ostomies, loss of domain with ostomies, really infected cases of skin and soft tissue contamination, and last but not least, enterocutaneous and enteroatmospheric fistulas that certainly present additional challenges. But what's common about all these patients that I just showed you is that, hey, they all have a hernia. And we certainly have this unique spectrum, and I think it's unlike any other disease process. The breadth of what the disease pathology entails is just so tremendous. And the algorithm of today's approaches is really very diverse. It's different from how it started, and has a bunch of procedures that are more or less recent. I showed this yesterday. There's just really an alphabet soup of things that we do and offer to patients these days. But again, I'm not going to do anything technical. I'm just going to sort of try to address the elephant in the room. With all these new procedures, the question is, how great are we? Are we just really great at developing techniques, and what is going on? And what's happening is that the results aren't that great. On the larger scale, the long-term recurrences complication rates are high. You can see the recurrences, especially over the course of years, continues to grow and approaching really alarming, 20+%. This was brought up yesterday. There's when you look at predictors, and when you look at the large-scale studies that include many population-based studies with some drawbacks of granularity, you can see the recurrence rate is up to 24%. And to think about in any other arena, if we were offering an intervention that failed 20 25% of the time, we'd really pause and say we're doing something wrong. And that's kind of what we're seeing in overall hernia surgery. Again, in addition to complications, the recurrence rate continue to be quite high in those studies. So just to summarize, where are we today? What is going on? And I think it's fair to say that failures in suboptimal care are really fairly common. And I'm bringing more like a landscape of the United States, but I think it might be applicable to Canada as well, because still, considering the degree of complexity of what the procedures are, there's lack of appropriate training. There's certainly a huge variation and misuse of advanced repair techniques. Continues to be inadequate access to specialized care, and it's reasonable given the frequency of the disease process. There's certainly lack of standardization and inconsistent application of quote-unquote best practices. We still argue about mesh selections in hernia repairs. We're still unclear about matching patient and a correct procedure. Robotics has entered the fray, and there's certainly growing concern about robotic misadventures because of perceived ease of performing these procedures. And the edited videos don't really do justice to what a surgeon might encounter in surgery. The postoperative complications and failure rates, again, as I've shown, remain high, even per expert hands. And if you think about include groin patients, inguinal hernia patients, the pains from nerve entrapments, plugs, poor mesh choice, wrong fixation is just not uncommon. And I talked briefly yesterday about botched abdominal wall reconstruction that continues to be a really troublesome thing. So having said all that, the time has really come for us, for the surgical community, to accept this responsibility and to try to address this frustrating reality. And recently I came across this amazing story about the shuttle, the Challenger, and the disaster that was surrounding that. And I want to kind of bring it up as a small parallel to what we might be going through. And just to brief it, so the story involves this man, Roger Boiselet, who was who worked for the contractor that NASA had hired to develop parts for the shuttle. And they were responsible for producing the so-called O-rings, and that were important for the shuttle for the solid rocket booster. So in 1986, during the shuttle launch, he and his colleagues became really embroiled in this fatal decision to launch the space shuttle Challenger. And so in this dissecting this anatomy failure is really fascinating to me. So the shuttle was launched after a 24-hour delay. So this is January of 1986. As you know, all the shuttles are launched from Florida. And it was unseasonably cold. The temperatures were in the 20s and 30s, and it was just remarkably cold for Florida. And the parts, the shuttle, the tests have never been done in anything below 50 degrees. So it was really cold, so they canceled the shuttle launch, and they rescheduled it for the next day, hoping it's going to warm up a little bit. It warmed up a little bit, but not too much. Interestingly, later that day, there was going to be a State of the Union address by the president, and they needed a little bit of good news, so they needed some positive. So this was a decision that's almost akin to some hospital-based decisions, where there's administration, there's all these different pressures, and so there's a teleconference call at 8:45 p.m. the night before, where the participants of the Marshall Space Flight Center, part of NASA, and the contractors from this Utah company that builds the parts. And Roger and his colleagues advised against the launch due to concerns that the weather is cold, and they would just really stiffen these O-rings and reduce their ability to seal the joints and create problems. So they're voicing this concern. And what they hear, and these are recorded conversations that just actually became public, and NASA's administrators say, "I'm appalled. I'm appalled by your recommendations." So this trained professional engineers say, "Hey, this is not safe." The administrator says, "This is ridiculous." And the other guy yells at them and says, "When do you want us to launch? Next April?" Maybe. But the engineers from this company, they were sticking to their guns. And interestingly, after almost 2 hours, the senior manager in the contractor, not an engineer, puts a hold on this conversation, says, let us get off the line and we're going to discuss this separately. So they break away. So now there's a conversation between the senior VP, again, not an engineer, this Thai call, who says to the engineers, am I the only one who wants to fly? And so the engineers, obviously in conversation, all of a sudden shift the tone. They ask them not to voice the concern that they may have a problem. They tell them, prove it to us that it's going to fail. So they literally say, you have to convince us that will it definitely fail? And they say, we can't say it'll definitely fail. But, and Roger says the phrase that kind of stuck with me. He said, launching the shuttle tomorrow will be an act away from goodness. And it's not goodness versus good and bad in that sense. It's an engineering term. And when you develop a model, you have this predictive model, and you have data points that sort of don't deviate from the model too much. So the goodness of this data is great here. But the more you have deviations from that predicted situation, that's deviation away from goodness. So that's how he meant it, but it certainly could be interpreted in many different ways. So he said launching the shuttle will be an act away from goodness because they never tested it in that weather. Well, they said, well, whatever, you can't prove it, it's gonna blow up. So they call back shortly and say, we're all set. We decided that we were wrong and we were happy to fly the shuttle. So they quickly fax the signed rationale over, and the rest of the phone call lasts 15 minutes. The next morning, they send the shuttle in 73 seconds. After the takeoff, it blows up and killing everybody on board. So terrible situation. Everybody's like, oh, how could we have known this? When you clearly look back and say a lot of it was known. So NASA forms the commission, the government forms the commission to really investigate this. And it's all been hidden until recently. But initially they say, oh, this rings broke. But obviously this commission investigating disaster reveals that this was just a part of the story. And they dissected and they said the commission concludes that there are flaws in the whole process, in the organizational structure, in the decision-making process. And all these things play a key role in the catastrophe. And actually, if you have an interest, there's this story that's not published away for goodness. It's dissecting this whole disaster and how it went on. But it makes you wonder, what if they approached this problem differently, And they didn't ask the question, are we great? They didn't ask the question similar to what we have to say, what are we going to do about this problem? And the problem with NASA wasn't just that the engineers were bad. The communication, the process, the certification, the approval, the clearances, everything was faulty, and it led to a disaster. So we, along the same lines, looking for solutions of how to stop the alarming instances of failures and trends that I showed you earlier. And I think to us, the status quo is just our act away from goodness. We just cannot allow that to continue. And the question is, should it happen on the individual level? Should it happen on the institutional kind of credentialing level? Administration, so insurance companies going to play a role in this nuances of this. What's the role of the professional societies? But at the end of the day, we probably all think the patients will drive the change. So next question, are we really ready for hernia abdominal wall surgery specialization and certification? And, are we really going to just all of a sudden come out and say that hernia is a subspecialty? And I certainly going to explain what we mean by that. And the first, an important disclaimer is there's a difference between a hernia specialist and a hernia center. And it's not the same concept. I don't think it should be exclusive, and there's no goal of marginalization. Doesn't mean if you're not a part of the center, you cannot be a good surgeon and provide good care. It's the expertise is skill-based, supported by training, experience. The center is just marketing tool, website design, should have certifications. But today it's often without merit. It's just shingle. And we certainly need more definitions. So again, are we ready for hernia special designation? And the truth is, it's the correct way to approach it is to call it focused practice designation. And again, when these days you have a question, what's the best way to answer it? You ask ChatGPT. Should hernia surgery be a specialty? Amazingly, Chad says hernia surgery is already considered a specialty in the field of general surgery. So there's enough written out there to support that it's a specialty. Specializing in hernia surgery allows surgeons to gain expertise in diagnosis, treatment, and management of hernias. They're able to provide more personalized care and use the latest surgical techniques. And again, overall, Chad thinks it's beneficial for surgeons to specialize in hernia surgery to provide the best possible care. So that means there's enough chatter out there that for the AI to continue to make these conclusions that we certainly haven't made in our society yet. But is the change coming? So the Wall Street Journal actually not recently published an article that proposed that there's a new factor when choosing a surgeon. The doctor you want, maybe the one who specializes in just one kind of procedure. What that means is that we have to really continue to offer patients something we do a lot and we do really well. The reality of general surgery training, increased complexity of abdominal wall surgery. This is a European experience. Again, increasing complexity in newer approaches. There's a steep learning curve in more complex procedures, without a doubt. And we certainly need additional training beyond traditional general surgery residency, similar to many other the changes other subspecialties have undergone. And what's also remarkable is how we as a group view ourselves. This is my partner did this survey of the American Hernia Society, and people who actually not view themselves as somebody who is a part of the society, they do hernia surgery. Interestingly, only 28% identified of the responders identified themselves as quote-unquote hernia surgeons. So it's a group of people who interested in the disease, but not highly predominant self-identifiers. So not surprisingly, TAR was their preferred approach, but mostly by hernia and high-volume surgeons. So, and only 7% learned it in residency. Again, not surprising given the novelty of the technique. So we asked the question, how many procedures did you think it required to master this procedure? So we're kind of a pretty arrogant bunch. So 65% said less than 10 procedures. And this is in a group that learned it post residency. And this is how people perceive themselves. And it certainly is from somebody who's done some in thousands. I can see that being a very incorrect assessment of quote unquote mastery. But the other interesting trend that we did discover that there's definitely differences in practice patterns in approaches. So you can see those who high and low volume use meshes differently. Those who identify themselves as hernia versus general surgeons use different algorithms. So we have already the trend where people, even in self-identifying way, will treat the disease differently. But the challenges continue because the general, quote unquote, general surgeons receive very broad training that encompasses various surgical procedures, including hernia repairs. And as you know, this is always a junior level case, intern cases. And by the time you're out in practice on your own, it's been years since you were really truly trained to do it, and you may not have been in best position to actually understand and retain the techniques. And at the end of the day, most general surgeons have limited exposure to complex hernia cases. There's lack of specific expertise. I think advanced surgical techniques and specialized approaches continue to contribute to those increased risks and failure rates. And it's not inherent to all general surgeons, as many have developed great expertise through focused training and dedicated experience. And I think there's a wide variation in those outcomes, suggests that we still have a lot of work to do. We need to better standardize training, skill optimization, and we have to create the specialized designations. And this is all done not to hurt anybody's feelings, but to really ensure optimal patient care and to reduce what we feel is still preventable complications, failures. They seem to be preventable events. The Europeans, as I said, have gone a little bit ahead of us. They have identified this need by applying these concepts. And again, we're noticing more and more that surgeons choose to attend more specialty meetings. Young surgeons begin to really seek abdominal wall reconstruction training. Our fellowship application numbers continue to rise every year, and the quality of applicants is increasing. And the European Board of Surgery actually approved the abdominal wall surgery as specialty already. In 2021, they have started administering oral examinations to certify as fellows of an abdominal wall surgery. And we're years away from that here, but we're kind of working towards some sort of thing, and I'm going to detail that in my subsequent slides. But another question, and before I do that, I want to kind of bring this up. Should anybody be afraid of that? And I think the idea is not to marginalize an average general surgeon. It's not to say if you're out there in the community and you're quote unquote average guy, you can't do this. That's not the idea at all. And how do we know? Because this successful specialty designation has happened in many fields. Not too long ago, there was no vascular surgery. There was no surgical oncology. Colorectal became a specialty. Endocrine is a fairly recent specialty. Breast surgery. And the latest, and I think one of the most successful examples is bariatric surgery. This has been a really, to us, bariatric surgery sort of has been the guiding light of how to go about making it safe for patients, making better overall, and elevating the field. And again, the goal is to elevate care and outcomes, and not at all to steal anybody's lunch. All right, so the American Hernia Society, and when I was president, created this task force to really investigate and come up with solutions. And I still continue to lead the task force. And we have done a lot of work, and we have several tracks there, and many people have dedicated a lot of time to define this criteria. So we're defining abdominal wall reconstruction in complex hernia. Guess what? It's not defined. We're outlining procedures that are expected and recommended for this specialty. We have to determine criteria, how to qualify somebody. Hey, I'm an abdominal wall surgeon. What does it mean? We're going to define measurable outcomes, quality metrics. We certainly have to account for practice variability. Is it academic, private, rural, urban? So we're going to work on that as well. We're establishing criteria for case numbers, hernia CMEs, etc., how to really continue to credential this. And we're using previous experience of ASMBS, as I mentioned, as well as European hernia friends to create good goals. And ultimately, we're going to engage American Board of Surgeons for focused practice designation. It's going to come years to come. And again, how to define experts, merit-based expertise, training, fellowships, who will decide? Is that American Hernia Society? At this point, yes, we want to take a leading role, but certainly the American Board of Surgery has to play a role, and we're going to work closely with them. But don't forget, we have frenemies, so, the longer we kind of take time to decide, somebody will decide for us. And it may not be as applicable in your healthcare landscape here, but it's certainly applicable to where we are. But ultimately, the patients deserve to be a part of this conversation. And I always say, when you look at these guys, and to imagine that they were not involved at all in that conversation that took place 12 hours before the launch, the fact that these people who were put in that position were not even aware that those conversations would take place, seems crazy to us, right? It seems like they were never even explained, if you will, an informed consent of what are they being put through, and just being left out of conversation seems vastly inappropriate. But I feel our patients are often left out of that conversation as well. We give them a form to sign for a informed consent for robotic TAR in somebody who's watched the video. And how do we really work on that, and how we define that and change that is complicated. So, slightly shifting gears. So do we need hernia centers of excellence? Is that really the answer? And centralization of care has worked in many countries and many other fields. And scope of practice of surgeons we know is narrowing. More complex operations are increasingly deferred to subspecialists into the centers. And again, high volume centers have been shown to have lower mortality in cardiac, pancreatic, oncologic surgery. It's been shown. Volume standards exist for other procedures. So why not us? national quality initiatives will soon set similar volume standards for other specialties, and I think including abdominal reconstruction. Because why? Technically complex operations have lower mortality when performed at high volume centers. That's the fact. A lot of investigations show that lower mortality mortality is lower when performed in higher centers. And again, this has mostly been done for cardiac and oncologic surgeries. So this is a little bit of another way to look at it. This is a Medicare data of over 25,000 U.S. surgeons who operated on nearly 700,000 patients 5-year period. So it's analysis of surgeon specialization and operative mortality in the United States. And what's really incredible, what they found is, again, in addition to the fact that specialized centers or high volume surgeons will have better outcomes, but taking it a little bit beyond that. Specialization was an important predictor of operative mortality, but also it's surgeons' specific procedural volume as well as the degree. So it's not like you do 200 ventral hernias and that means you're an expert. It means you do 200 out of 250 cases you do that year. So not only you do more of some procedure, the percentage of that procedure, of that dedication is significantly larger proportionally in your practice. And they're showing this to be a huge contributing factor to success and lower mortality. So will centralization happen? And I look at the history of surgery. This is Andreas Paret. He's considered to be a father of surgery. But what they did, they abolished boiling oil on wounds to sterilize wounds. That's how they used to treat it. So clearly, we have gone a little bit away from that. But he's the father of modern surgery. Operating rooms used to look like that. For theaters, this may have been an operating room at some point, and you can see anesthesia was primitive. So we have gone a long way. At some point, when I was a fellow, we looked at these OR1s, they call them endosuites, and I'm like, oh my God, this is so futuristic. But then it became the norm, and now our operating rooms look like this, and very commonly. And the robots make it easier. So even you can see my 7-year-old can easily cross over during ETAP, and all kidding aside. But there, you can see she's this is my meeting wearing her pajamas. She's doing robotic tasks. And this is David Chen kind of guiding her. And she doesn't know how to clutch. Her feet don't reach the camera, but they're able to complete these tasks relatively easily. And it's incredible to watch these kids do that. And again, it's coming and it's going to make surgery better. So how to characterize hernia center? This is a paper published in 21. They looked at 320 programs with surgical trainees across the United States. 36 of them had quote unquote hernia centers. 284 did not. And there was no universal definition of hernia center. There was nothing that would tell you anything more than that. I'm in New York City. I type a hernia center where I live. There's going to be a long list of hernia centers with all different names. New York Hernia Center, Columbia Hernia Center, it's us. Laparoscopic Surgical Center, hernia in New York. Our friends at Cornell call it Center for Hernia and Gallbladder Surgery, Core Surgical, blah, blah, blah. So there's a lot of centers, but what does it mean? And we don't know what it means, and we're trying to figure out. So we're proud to sort of have started a conversation, and this is our brochure, and there's some marketing words here, but looking a little bit beyond just words. We say we bring together a group of world-class physicians. That's us. But again, delivering highest personalized care. But this is just marketing. Anybody can say that. We can. There's nothing else. So, but we can also say all our faculty is fellowship trained in eyeball surgery. We have a track record, and that's beginning to be different. But again, and this is our group, and what's important, it's a center. We have surgeons, we have a bariatric surgeon, we have orthopedic surgeon because we deal with a lot of athletic pubalgia. We have NP, patient care coordinators. This is from a few years ago. Now we have a quality officer. We have grown to 4 attendings, and I think this is the blueprint of what a hernia center might look like. And the Carolinas group also put together this nuts and bolts. What does the center have? And it should have this institutional participation, robust algorithms, outcomes research, teaching, and so forth. The Germans went a step further. They really have tried to put numbers. So if you want to be called a hernia center, this is what you need to have in your center. You need to have documented rates of low complication rates and reoperation rates and all kind of infection rates. So trying to put some data to define that. But ultimately, this is from Barcelona. This group has taken it further and looked at abdominal wall surgeons versus general surgeons for hernia repair, and they found not unexpectedly that specialists have better outcomes. Incisional hernia surgery is associated with better results in terms of recurrence when performed in a specialized abdominal wall unit. So, Center of Excellence is another track for the American Hernia Society task force. We're still working to define criteria. We're going to determine the purpose of designation. Is this pride? Is this marketing? Is this for patients? Is this for insurance companies? Who needs that? And what's excellence? How do you define excellence? We're going to establish minimal case volumes. We're going to mandate tracking outcomes and define the body who's going to govern this. And again, what's the process and who's going to be administering this? So in conclusion, I want to sort of ask this question. So what is our act towards goodness? And we certainly have to recognize it's a problem. It's not all unicorns and roses and rainbows. We're not that great as a group. And I strongly believe the status quo is no longer an option. It's not just an option to continue as business as usual. I think we're ready for abdominal wall surgery to move towards focused practice designation. There's got to be recognitions. There's going to be designations. I think, again, at Columbia, I was proud to start the first of its kind formal division of abdominal wall surgery. We're not going to be the only ones. There's many other large institutions in the United States that have laid the foundation towards sections and divisions, and I think that's going to be important. It helps in recognition. It helps in adoption of this. We're certainly going to continue to demand robust data tracking as part of a credentialing process. We're looking for ways to improve training and figure out levels where that could be achieved, whether resident or certainly fellowship training that we provide. We continue to define and credential what a hernia center of excellence is. So when a patient goes to a center of excellence, it means something and not just a marketing ploy. And I'm hoping that my work and the work of our American Hernia Society is going to be really instrumental in that goal. Because again, in world of hernia, I think it's in the words of Yoda, it's do or do not. There is no try, because patients can get hurt by incorrect procedures. So thank you very much, and I was happy. It was fun to be here, and hopefully you guys had a good time as well.
Thank you, Dr. Novitsky. Thank you for that wonderful talk. I think it really does a lot in terms of identifying the evolution of the specialty, and I think towards elevating our practices and standardizing our practices. Yeah,
You're the one, Chad, that's going to be chat.
And well, can we unmute to ask a question?
Yeah, anybody can ask the question.
So I'll look for. I'll invite the audience to unmute since we have some time. Dr. Paraskevas?
Yes, thank you. Can you hear me okay?
Yes.
Thank you, Yuri. It was great. I really enjoyed your perspectives and seeing some transplant patients in there. Makes it very personal. But my question is, are we heading towards a type of training model where residency becomes kind of a basic training, and after which either while you consider yourself still a trainee, or even perhaps while you're on staff as an assistant professor, or even beyond, you amass certifications of one form or another, either wide, diverse certifications or highly specialized or particular technical certifications, and that becomes our sort of currency of either applying to positions or even centers looking for particular practice profile will look for particular certifications, and residency will become kind of a basic training for a multitude of potential certifications, either technical or otherwise, that you get after that. And then, I say this as someone who feels that the specialist is the one who is where innovation is really driven. But I kind of see these as complementary. Like, you can become a specialist with one or two particular certifications, or you can become a generalist who works in a community setting with 5 or 6 or 7 different certifications. And I'd like to get your thoughts on that.
So all of these things are poorly defined, and we're still struggling to really do it. And the hernia is a little different because it's so common, and it's going to be a gradual process. So we would certainly love to have residents more and more prepared. But if you look at the landscape, when there's not enough attendings who are specialized, it's hard to imagine that we kind of have enough volume to all of a sudden translate into robust resident training. So it's going to be a process, I believe. Again, what's complex, right? Who should be doing what? And at some point we said, if you're out there and you have a very good practice, but you don't see recurrent hernias, so somebody comes to you with a 3-time recurrent ventral hernia, maybe that's the breaking point. Is the recurrence, so everybody should be able to fix first time, when the recurrent hernia should go to somebody who is specialist, and multiple recurrent should go to centralized area. So that's something that we're looking to define as well. We have a fellowship, but in the States, there are probably 4 or 5 true ABWOL fellowships. There's probably another 10 or so MIS programs who give what, in my kind of estimation, like minor in hernia. So we have like majors in hernia, and we can offer minors in hernia. Is that enough? And it's certainly not enough training sites to have sufficient number of people. So we're working slowly towards that goal. And unfortunately, this is the process when I feel it's even more dangerous when some expertise is available elsewhere, but the patients continue to get suboptimal care. And I just call upon surgeons to recognize their limitations, to mostly the change coming from within, to understand that just because you're a general surgeon doesn't mean you should be doing all these procedures. And to your last point, some of the data shows, it's hard to be an expert in 4 things. It's hard to really, even if you do 1,000, 200 of each a year, you're probably better off doing, 200 of one thing. And it just shows your passion for the disease, your understanding of comprehensive problems. It goes to procedure selection, to mesh selection, to management of optimization and complications. So it's not just this ability to do many things. And I think it's going to be a gradual change. It's just hard to imagine we're going to be ready for this overnight. But the conversation has started, and even ChatGPT is on our side already.
Right. Dr. Fale, do you want to unmute? Thank you, Steve.
Thank you very much, Dr. Novitsky, for the great talk. And my question was mainly for the abdominal wall resection. We encounter those frequently in surgical oncology, and we end up with this big hole that we figure out how to close. So my question to you is actually 2 parts. The first part, at your institution, is there like a multidisciplinary team that usually you see these cases beforehand? You plan if they need a Botox injection, all these stuff. And the other part, in your experience, when you are faced with such a situation, is it better to start just with a mesh repair and keep the TAR as the next step if the mesh repair fails? Thank you.
Very broad question. So we don't have like a tumor board. We have hernia rounds where we bring up cases. So that's being discussed, and anybody can bring their case, but mostly it ends up being our division, our fellows kind of talking about things. So our surgical oncologists who specialize in desmoids and things like this have talked to us. It's interesting that traditionally it was all plastic surgery. And plastic surgeons in these settings often utilize what we now think is suboptimal kind of biologic mesh bridges and things like this. And it seems like, yes, it's safer, but then the patient comes in with this huge recurrence, or they have a big underlay bridge ventrolite or something like, synthetic mesh. And I don't think it's optimal. So, we now work with our surgical oncologists. We often do these things concomitantly, and I have a fairly good experience. Again, these are not cases we do every week, but maybe 5-6 times a year we'll have to join in, and I do single stage reconstructions. I'll go for it and I'll reconstruct the abdominal wall. And there was a case recently when I didn't do it. I left it for future references, mostly because this lady had was planning to get pregnant. So she got pregnant. She got tumor discovered during pregnancy, and so they had to interrupt that. And she had a large rectus desmoid that they treated with neoadjuvant therapy. It shrunk. She ended up getting a big resection, but she wanted to get pregnant. So I'm not going to do a formal reconstruction. So we're able to do external oblique release and primary repair with just a little phasix onlay to hold her together until she is done with childbearing. But oftentimes I'll do formal reconstructions right there, because I feel this is the best time. Remember, the muscle is very pliable. Even when, in these cases, when you take out even a big chunk of the abdominal wall, because the patient did not have hernia to begin with, they don't have the stiffness of the lateral abdominal wall. So you're able to advance and create significant advancements of musculofacial complex, even in large resections. And as long as we have good skin to cover the defect, it's going to be enough. So oftentimes, not often, sometimes when the resection is going to have sufficient soft tissue loss, we may need free flaps or rotational flaps to just cover the mesh and then produce some skin on top. But this, even in a center like Columbia, this is not very frequent problems, and I think those should definitely be done in specialized centers.
Yes.
I really like the parallel that you drew with that NASA example. I think it applies to all of us. I wanted to get your opinion more on, because it does put the patient first, the patient in the middle, and obviously it's that thing with the price of our society, and then on the field. So investigating these centers, how much are outcomes, how important are outcomes, and how transparent should we be in reporting that and that accessible to patients? I did kind of train in the US for ICU surgery training, and it's the star rating system where you have to report outcomes on some index procedures, PDR, etc. Should there be something like that? Hernia is knowing the variability, but there is some kind of connection that information. And how do we do a better job at transparency?
I think so. The patients certainly have to be informed, and again, the desire to be informed varies regionally, right? Again, in different parts of the world, the country, it's going to be the desire to have this information is going to be, the appetite is going to be different. I certainly think it should be. The challenge with the hernia field, it's so diverse. If you look bariatrics, the endpoint is weight loss or leak. The anatomy is roughly, in transplant. Report your creatinines, and that's the definition. Graft loss, very defined. Cabbage, it's a patency of grafts, heart attacks. We have patients who, the classification of hernias is not comprehensive. We can classify by wound status, by hernia size, by width. We're trying to figure out the staging when maybe the certain things could be now grouped, and you can report your outcomes for stage 1, 2, 3, or 4. Because if it's only going to be recurrence, then I'm going to not take on complex cases. Let me just cherry pick and have my outcomes so much better. And again, so we have to be careful of how to report outcomes, considering that patients' hernias are different. And and I think staging is going to be one of the answers when we can really compare apples to apples. And
And I think the more complex it is, more difficult for people to wrap their head around what it means, right? They can look at that.
patients think they come to me and they say, how come I have to be in the hospital for 5 days? My neighbor had a hernia and they went home the same day. And I said, what kind of hernia they had? Like, I don't know. And just, it's not just surgeons. It's everybody says it's just a hernia. Like, this guy had a hernia. He went to the hospital, came back, and here I am. And meanwhile, they have this like glossal domain that they've had repaired 7 times. So we have to make a better way of defining, to me, that staging that we are working on, it's similar to TNM, right? It's a hernia patient width. So it's a hernia type, the patient comorbidities, and the wound class classification, and maybe grouping it that way is going to help us to at least somehow define patient populations and taking into consideration really these various parameters of the disease. But it's very challenging. So part of the challenge of our task force is we're working on definitions. We're still consider ourselves experts of undefined field. So we're coming up, we're making progress in defining complexity, defining what it means, and I think with that will come better understanding of all parties involved. But you guys live in a different world. We have insurance companies who can say, oh, we're not covering that. And on one hand, listen, I'm in New York, we're a big center. Okay, selfishly I can say, yeah, let's do that. But there's way too many people. There's way too many people who need these operations. It's not fair to say they should be done in these like little centers. There's 50,000 hernia repairs currently done in Greater New York City a year. That's 50,000 surgeries. Like it's a lot of procedures that need to be done well. And if you have a complication rate of 5%, that's a lot of miserable people. And the misery after an incorrect hernia repair is years of pain and disability and recurrent surgeries, and forget about infections and fissures and all this stuff. So I think patients need to be involved. I think if we don't do it, somebody will do it for us. We're active to change that, but it's work in progress.
I guess in light of like this, I think across the general perspective, the everything's kind of moving towards something. I think do you see that widening sort of health disparity, rural versus urban centers, where in smaller centers, like I can't imagine we would have these complex centers for these adult volumes of what people would, Laura was talking about, status, less health literacy, all of the reasons for COVID, and having these conditions that don't get looked at.
For sure. It's a big problem. It's a big problem in New York City. It's a big problem in the rural, and it's not and the disparities could be qualified in so many different characteristics. And again, if you are not near anybody, any large center, you won't. And even large centers don't necessarily have that expertise. When people think they're experts, but don't really do this, so it's difficult. And sometimes Columbia is in Washington Heights in New York City. It's very the population is not well informed. It's not certainly well off, but they can just walk in and get care by us. So it's not always just patient characteristics, but the disease is too common. The expertise is still limited on a larger scale. It has to be sort of really addressed globally, on a larger scale than just hospital, region, state. And the status quo is what you're describing. You do the best you can, but we need to change the status quo. We need to continue to train enough people and create enough awareness. And UK, for example, In the small scale, it's easy to do because in England they have, if you have a fistula, you don't go to one, you go to one of three places, right? So the intestinal failure, they call units, there's only three. So not everybody. So as soon as you have this complex disease, the insurance with NHS drives you to where you're going to get your care because they found this is going to create less infections, better outcomes. We can't have that. We can't have AWR centers, you know, unless we want to put it next to Starbucks or something. You know, it's too much. But maybe something along those lines, chains of certified centers where they could be specialized. You know, somebody. You know, I have patients who travel. People will travel. They're so miserable. They will travel to get it done, right? But it's not like we always win. We have complications. So you need to be prepared to deal with complications. You certainly don't want to take a simple patient and make them complex. The priority is to take a complex patient and make them less complex, but definitely not to take a simple patient and make them complex. So this, I have a whole talk on that. But that's, so this is the things, but the access to care is going to continue to be a big problem. And that's why we're not coming out, say, American Heart Society says only these three guys or girls should be doing this. It's not correct. If it's correct, it's just to define things and train people but take it seriously. You know, you guys also have a unique position being in a larger urban center to create, lead the way in sort of creating that change in perceptions. You know, my hospital, hernia is no longer like just general surgery referral. They refer because we have a division. Thing is changing perception where these patients are referred. And again, bariatrics has done a great job salvaging the specialty. They were threatened when I was a resident. The outcomes were poor. It was almost a moratorium on the whole field, and they had to organize to do the right thing for the patients and for themselves to be able to provide standardized procedures, outcomes, data management, certification, credentialing, all this stuff. They've done an amazing job. We're following the ASMBS footsteps in many ways. And I think hopefully that's, you know, a couple of years down the line, we're going to have somewhat a similar model to that. We're not inventing wheels here.
Well, thank you, Dr.
Time.
Novitsky. This is a
Time's up.
phenomenal talk. Thanks it was a great discussion after rounds. So thank you again for coming down.
My pleasure. Thank you
As
for
soon as
inviting.
we find your glasses.
I know, I have, exactly. I have backup, but. All right. Thank you very much. Thanks everybody for being there.
Thank you.
All right.